Beyond reduced EPO production, there is an additional and often underappreciated layer of dysfunction worth understanding. In chronic inflammatory states, the bone marrow's sensitivity and responsiveness to whatever EPO is present can be blunted by circulating inflammatory cytokines. This means that even when EPO levels are not dramatically suppressed, the marrow's ability to respond to that EPO signal is diminished. The receiver becomes less responsive even when the signal is still being sent, adding yet another reason why red cell production slows in this condition. Taken together, the full picture of anemia of chronic disease is one where three mechanisms converge simultaneously. Heme synthesis is impaired, EPO production is reduced and its effectiveness blunted, and iron, though present in the body, is locked away by hepcidin and cannot be mobilized to where it is needed. Each of these mechanisms alone would be sufficient to cause mild anemia. Together, they produce the sustained and self-reinforcing anemia that characterizes this condition. The laboratory pattern that most cleanly captures anemia of chronic disease is low serum iron, low TIBC, and normal or elevated ferritin, with the elevated ferritin reflecting iron that remains trapped inside storage cells rather than circulating freely. Contrast this directly with iron deficiency anemia, where serum iron is low, TIBC is high, and ferritin is low, reflecting genuinely and completely depleted body iron stores. This three-marker pattern remains one of the most powerful and reliable diagnostic tools available and represents a clinical foundation that is non-negotiable to commit to memory. Erythropoietin EPO resistance in anemia of chronic disease, ACD, arises from a combination of inadequate EPO production, often inappropriately low for the degree of anemia due to the suppressive effects of inflammation, and decreased bone marrow responsiveness to circulating or exogenous EPO, frequently driven by inflammatory cytokines and iron-restrictive states mediated by hepcidin. Key mechanisms include iron sequestration, functional iron deficiency, elevated hepcidin, and direct suppression of erythropoiesis by cytokines such as interleukin-1 and tumor necrosis factor alpha, impeding both endogenous and pharmacologic EPO effects. Mechanisms of EPO resistance. Inflammation leads to decreased EPO production and increased resistance at the bone marrow level through cytokine action and iron restriction. Addressing the underlying inflammation, optimizing iron stores, and considering adjunctive or novel agents targeting hepcidin or inflammatory pathways may improve EPO responsiveness in anemia of chronic disease.